So I would like to first thank you. And honestly, we are humbled and honored to have Dr. Srijon Mukherjee with us here today. And he has graciously agreed to take time out of his schedule to present on the application of digital technologies in maxillofacial surgery. Dr. Srijon Mukherjee has been practicing the complete spectrum of oral and maxillofacial surgery, from aesthetic facial surgery to advanced head and neck, skull base oncosurgery, as well as craniofacial, corrective, and reconstructive surgery for the last 17 years. He has numerous international and national publications and presentations across surgical specialties on traumatology, orbital surgery, regional unusual pathologies, airway interventions, and neck surgery. He's also a leading proponent of training the general maxillofacial surgeon as a priority in India. With this idea in 2008, the Calcutta Institute of Maxillofacial Surgery, as is known as CIMS, was established as the first non-trust, non-corporate, single specialty maxillofacial hospital of Eastern India. Apart from being a regular faculty for MDS oral surgery for Rama Dental College, Kanpur, Dr. Srijon Mukherjee is an invited honorary faculty for MCH plastic surgery at the prestigious Calcutta Medical College, and he's also an examiner at the Royal College of Surgeons of Edinburgh, UK. He's also a consultant at Calcutta Medical, Fortis, Kolkata, and Apollo Gleneagles Hospitals. And we are very honored to have him here with us today. So without much ado, I would like to hand over to Dr. Srijon Mukherjee for his presentation.
Thank you. I'll just get the screen here.
Yeah. Shomesh, can you allow? Yes, thank you.
Yeah, just so can you all? Okay. Just we are in the process of. I'm more comfortable with the use of digital technology in surgery. Here I'm finding a minute or so of trouble to get my presentation on, which is here. Yeah, okay. I think it is going to show now. Thank you. So there it is. Can you see the first slide? Are you all there?
Yes.
Okay. So we are going to talk about digital technology in day-to-day oral maxillofacial surgery as we practice at CIMS and many other areas. We are regularly into this now. I must, because this is very important for. I think there are some postgraduate students in our panel of people who are now listening to this. For them, I need to mention that it is an important part in the last section of final year MBS. That is the present new technologies in the subject. So to take a note of this, I have covered most of the area apart from one which I do not have much of an access to, which is digital navigation. I think that will be covered by some of my other speakers today. Okay, we have moved on from the point that the CT scan became 3D. As you see, there is one which we are very used to now. Gradually, day to day, our consultation tables are going to look like this. That is actually, one day I got a few of the skulls, the 3D models on the table, and it was looking somewhat like that. And we use 3D technology in distractions of all sorts, in complex volumetric corrections of orbit primarily, extensive deformities in trauma patients, recontouring surgeries in fibroosseous lesions, and reconstruction plates are sometimes also adapted on 3D models for certain areas. I will show the examples. That is all the presentation is about. It is used for strategic aesthetic correction templates, and nowadays we are using it regularly for total joint replacements, especially in the custom joints. And the patient-specific implants is the biggest use, where directly the digital technology is going inside the patient and staying with them. Starting with the placement of intraoral maxillary distractor, that these are real pictures, how we do it before taking the patient to the operating theater. It helps greatly in the 3 points of parallelism, planning of planning of the osteotomy. As you can see, the pencil lines are drawn there for the osteotomy cuts. What happens is if you're just placing it at the time in the operating theater and bending it, rebending it, it is not only time consuming, but there are other problems. The biggest problem comes in parallelism, because parallelism is in 3 dimensions. I'll show you how it works. You see here, there are the 2 distractors placed, which you see the before and after situation, where you can actually almost see 1 cylinder, not 2. And that is how the parallelism should be. And it becomes extremely easy when we do that before we start the surgery on the 3D model. And as a result, move on to another form of distraction where we do the transport disc. Transport disc distraction, we do the full distraction on a 3D model, and we are sure where we are going to dock and how things are going to move. This is a makeshift transport distractor. We are not that rich to have the real, the best ones, so we make it ourselves. And that's the surgery. You see the distraction which you had seen exactly on the 3D model, and it goes on. This was a patient who actually was a patient of osteoradionecrosis. That's why the skin tissue is bothering over there still, but we have got a mandible. We guide for multi-directional distraction. The 3D distraction, the distractor that you see lying over there in very complex defects, it is essential for us to prepare beforehand. It is used in hemifacial microsomia, severe mandibular hyperplasias, various craniofacial syndromes, and in some post-ankylectomy cases. I'll just show one example. Hardly any, obviously you can identify the syndrome here. Hardly any mandibular ramus or condyle. Very difficult to directly go ahead with the distraction for that mandible. But it becomes very easy when you just put the osteotomy cut there and take the remaining segment to the desired area, fill the void with wax, and you get the mandible that you are targeting. And you are now ready with your distractors. You know the placements, you know the osteotomy lines, and you get your result. You get a mandible out of almost nothing. This is just immediately on the day that the distractor was removed. Next is the volumetric correction of orbits. In multiple ways, volumetric correction of orbit is a challenge, because we have to do it with, we cannot do it with complete vision. It is often done under a partial accessibility. So if we have the things done on the 3D model beforehand, makes life so much easier. It is also good for safety margin. Here you see a proptosis which was corrected, and on the lateral wall of the orbit on that side, you can see a hole which was created from beforehand, and that was the safest position to remove bone and then extraconal fat from there. So a template could be made by cutting a small aluminum piece, which template was placed at the time of surgery. That exact hole was reproduced in the lateral wall of the orbit, and the volumetric correction was achieved. If you see it is the right eye, where it is touching that line, and in the next it is behind the line, whereas the other eye has come to the same area. These are things which you are actually approaching from just one aspect. In a 3-dimensional area, you are just getting one aspect open. So it is important to have a control, and I think the 3-dimensional technology gives us the only available way, apart from also navigation at the time of surgery. This is another similar situation while handling a trauma. There is hardly a guide. If you see the CT scan on the side, hardly a guide to have the volume that we have to reproduce, because there is no piece of bone that can anatomically reduced, and it is sort of quite old. So we are not going to get what we require here. So what we did is just taken out that small piece first, taken an impression of the opposite side, and created so replicated the volume, and we prepared everything beforehand went in, mobilized the bone pieces, just followed, used the plates as template. If the plates which were pre-bent on the model, if they were fitting nicely, that means we are in the right place and we got the volume. Recontouring surgeries for fibroosseous lesion is often very tentative. You reduce kind of what you think is the most suitable, but that may not be the right volume. 3D technology can help us in this situation as well. You just do a mirror imaging, the mirroring of that side, which you can see in the first model. You have mirrored the side, and on the side that is to be trimmed or that is to be sculpted, we will make, I will show you what we will make. Exactly same thing has been done in the mandible for the other case. So we make this kind of templates, and these templates will actually allow us to reduce exactly as much as we reduce. There you see the bone is being reduced, and the template that we prepared, the transparent template, we place it in that area. Till it doesn't fit perfectly, we would have to trim. So when it fits perfectly, you have got a perfect replica of the other side, because this template is based on a mirror replication of the other side. Same thing happening with the bone. Here it is more of drilling, and you fit the template and you get the result. Adaptation and contouring of reconstruction plate in resection cases. Why do we need that? We can all bend the plates. Yes, it will be a little easy, but sometimes it becomes essential. This is the case of a osteomyelitis, where a part of the mandible is going to go, and due to severe COPD, we have to perform the procedure under local anesthesia. So under local anesthesia, I didn't find it suitable to fiddle around with bending and rebending. So a simple 3D model helped me by the same process. Opposite side was mirrored, and we contoured the plate according to that side. It went in no time. Here is another area, the craniosynostosis cases, where we use 3D technology extensively. You see how the 3D model in the central section, you can see the 3D model has been operated upon already, and we exactly know how much gap we are going to leave back. Otherwise, we might feel very threatened to leave that much gap, but we knew from before that that was essential. And you see the same gap is replicated just below that model, and we got that kind of a craniosynostosis corrected. There are certain times where craniosynostosis can give real challenging situations, and there we have to fiddle around with the bones a lot before we can achieve, like we can really fit the jigsaw and get a good result. So in these kind of situations, this is a failure of somewhere else, an S institution, and there was a refusion where the head was getting taller and taller, and we had our own technology of switching the calvarium, the right side for the left side, upside down. This is a technique which I use, and I developed that technique only after I had started playing with the 3D models, because I saw that it was working well. And there the procedure is going on. The bandeau is being removed and replaced. See, the bandeau is coming back. This is the head afterwards. Just to remind you, this is the head that we started from. I would have not felt very confident to do this without my access, extensive access to playing with the 3D models for all the time that I wanted before I went into the surgery. This is the child now. The next area where we are finding the use of 3D technology is in orthognathic surgery. This is not the result that you see over there is that of a traditional splinted surgery, a biomaxillary surgery. However, there is something called splintless surgery that has come in today, which has removed these stages of models, face bobite, articulation, model surgery, all that stuff has been eliminated. And the wafers, which we trusted so much, the splints for orthognathic surgery, there was nothing, no orthognathic surgery was proper without the use of splints. This is a case of a Bimax where first you see the interim and then you see the final splint. There is a new approach of splintless orthodontic surgery, and that is again a PSI. You prepare not only the final plating system, but you also prepare surgical jig so that the final plating system doesn't betray you at that time if the lines of your surgical cut were different. So this I'm using a web page here just because I don't use it. I cannot afford to use it yet, but I hope I will soon. As it becomes more and more available, it will become less expensive. So that is the splint that you see. A metal splint has been fabricated, which is there just to put our cuts in the maxilla. And after that, there is a custom plate fitted, prepared in the new position of the maxilla. So that is the plate in position. If you remember, here was the cut, and there's the plate. Same thing for the mandible. That's how the template comes in. And the template is showing in the figure D. The template is showing where we are going to put the cut. We have placed the cut, straightforward BSSO cut, and then we had prefabricated plates which will go in exactly at the position required, and you get the desired result. This, at some stage, will replace our routine plaster and wax business of splint, maybe. But, well, when possible, this should be very precise. I was in a debate in the last national conference where I was against the concept of complete splintless surgery because I was calling this internal splint. So it was a trick of debate. And we did actually, it was more of a win. We didn't agree that there can be good splintless surgery. We said, yes, this is a surgery which you are calling splintless, we are calling internal splinted surgery. Now we come to the last section of the regular use of 3D technology. It's like
for preliminary design, we have
yeah. So there is a lot of discussion that goes on like this, and after which we proceed to prepare the PSIs. I will just show 4 recent cases of PSI that we performed at the institute. This was an older defect of a resected AVM, and this is how the inside was. You can actually still see some of those coils left in the vessels. So just a simple opening and getting your prefabricated PSI in place. You see the position of those implant sockets over there. Dream of an implantologist. Ideal position, ideal height, everything correct because it is all man-made, machine-made, digitally made. And we just place as many screws as you want to feel comfortable and safe. In maxilla, this works very well. In my experience, it is best for maxilla because water doesn't travel upward. So in the mandible, when we do the same thing, I am always scared that there will be trickle down of saliva with bacteria inside, all the way leading to the points where my holding screws are holding the PSI. So I avoid the mandibular PSI. All the PSIs that you will see I have done are with maxilla. So this is the PSI in position. And that's a prosthesis. The prosthesis looks old because the patient was so comfortable with her old obturator that we cut the top part and converted it into an obturator that fitted in our prosthetic design. And this eliminates huge big surgeries and complexities of free flaps. Free flaps are fantastic, no doubt about it, but sometimes you can get away and make life much easier for both yourself and the patient with this simple digital friend of ours. There's another one, and this one is from the recent time of the saga of black fungus. We had to remove the whole of maxilla, most of maxilla for this gentleman. You see, the maxilla has been removed, one side completely, and other side only the posterior aspect is still there. That's the PSI, simple PSI prepared in India in short time, after a lot of discussion though. And that's there's exposure, there's a placement. As you can well appreciate that this is no big deal. It is much, but the number of people who will be happy to do a free flap over there, and the number of people who will be happy to put in this PSI on that same patient, you can easily understand the difference. And for us, more patients benefited is what we are here for. So that's the PSI being firmly secured. That's how it looks inside the mouth. And that's the OPG. That's the processes. That's the patient. Another one previously operated, there is a free flap there, but that free flap is just a soft tissue flap. And the patient wants something to support his upper left face. Here, there were so many incision lines that we could easily open it because we needed a cheek support here. So we just opened it, placed a nice framework. On the other side, the incision is for a nasolabial flap because, as many of my maxillofacial friends know, that we do get a lot of patients operated for oral cancer who do not get their oral submucous fibrosis corrected, unfortunately. And so they return with a closed mouth, which is something that should have a lot of attention and should be banned. This way, it should not happen. So anyway, here we were in a position, they actually did such a nice free flap, but not anything to open the bands on the other side. So there was a tiny mouth opening. So we had to do this at the time of placement of the PSI. This is the last one. This was a recurrent case of central giant cell granuloma, where we had to remove a lot of maxilla there. And again, PSI was our solution. Very same picture, all of them. And there it is. So it has become a very simple solution where we don't have to think much before going ahead. And it is not that expensive either at the moment. The last use that I'm doing nowadays, this is a very recent pre and post-op of a mandibular. The prosthesis that you see there and the patient that you see are not the same. The prosthesis is bilateral prosthesis, because I found that I didn't have a separate picture of the prosthesis taken before the surgery. So I placed a previous prosthesis there. This was a lady who had ankylectomy surgery done before, and we extended the mandible afterwards. So what is the special advantage of these custom condyles? We have a mirror referencing, and then we can design and redesign how we are going to get the fossa component and the condylar component. And this is a very interesting phase. This is a long phase, actually. If you are going for PSI activities who have not yet started, you should know that this phase can get pretty frustrating. You see, I was shown once this kind of a design for the side affected, because the engineer over there who was the designer, they would not know that the teeth can be put apart. So the teeth which were together was giving a very little space to them. So they very kindly didn't move the jaw at all and produce that kind of a design, which obviously had to be changed. They will also produce designs where which cannot be introduced. This was a jig. This was the jig fabricated for the case that you have seen. The jig design was like this, where there was the internal wall. And if you are actually entering that area, there is hardly a possibility for you to get that wall inside. So that is because the person who is designing this is not conversant with the anatomy of the pterygoid area. So there was this wall which I asked them to remove. That's how I asked them on the phone by drawing with my finger. And finally, this kind of a jig came. You see at the top corner, and the jig worked fantastic. Okay, this is just the market leader. This is how the best quality jaw joint, custom jaw joints look like. But we get something reasonable anyway. I will move on from this. This is not. Yes. So this is the result in that lady, the mouth opening. Obviously, the mouth looks pretty dirty because she has opened the mouth after quite a while. And that is the Indian custom joint that you can see on the side, which was the result of the discussion about which we are talking. And that kind of brings us to the end of my presentation of use of digital technology in my regular practice. And I think this covers a good chunk, but there is even more that can be done in the digital technology use in maxillofacial surgery. Thank you.
Thank you, Dr. Mukherjee, for that really enlightening talk. I would like to open the floor to discussion. Any questions that anyone might have? This would be the time to ask if you have any questions on the talk just given by Dr. Mukherjee.
You can unmute yourself and ask the question.
Yeah, actually, you see, it is such a simple thing that hardly any questions. Anybody? Because I myself, maybe I'm using it for last 5-6 years very extensively. So I believe that I can answer some of the questions, some of the complexities I've faced in it, if anyone has any doubt.
Dr. Harsh, I think you're trying to ask a question. We can't hear you. Not yet.
Cannot hear you. Please, if you just click on unmute. Yeah, probably.
Or Dr. Harsh, if you want to put your question in the chat. Actually, there is a question in the chat. Let me just read that out for everyone. There's a question from Prasad Vagadale. Hopefully I pronounced your name right. Is there any case of exposure of PSI in post-RT patients?
PSI is not the ideal solution in post-RT. When we know that a person is going to get radiation therapy, we would not recommend a metal piece to be your substitute for bone. If you know that this patient is going for radiation therapy, and if there is a need for reconstruction, especially of mandible, most of the cases would be, it is free fibula. There is no doubt about it that is the gold standard. What happens is radiation gets reflected from metal, and it is double radiation to the skin above the metal, and it is bound to get excoriated, whatever metal it is, a simple recon plate or a PSI. So it is not recommended. Long after radiation, if you are doing a secondary reconstruction, which I have done in one case that I had shown there, it is perfectly fine. The number of years that we are watching them is not too many. So till the time I have not seen excoriation due to radiation, because I'm talking about quite a few years down the line after radiation that we have placed the implant. If we are placing an implant in a patient who is now to go and get radiation, I would never do that.
Thank you, Dr. Mukherjee. There is another question from Dr. Harsh Dhar. He wants to know if your experience with zygoma anchored implants post macillectomy, and whether you routinely use an issue cover over the implant.
Zygoma, I think you're talking about zygomatic implants, the dental zygomatic long implants. We routinely use zygomatic implants, and the zygomatic implants get thoroughly covered with soft tissue inside the mouth. I would normally press my, if you are using zygomatic implants, the diamond drill, the side cutting drill, I would press it all the way till the drill gets completely disappeared within the margin of the bone. So my zygomatic implants are 90% inside the bone. The little bit of the bulge which is outside is always covered by bulky amount of oral soft tissue.
I think that answered the question for Dr. Harsh. Yes. Okay, great. This presentation is being recorded, so if there is any follow-up question, we can always go back and ask the panelists for the answers. But we have about 5 more minutes for this section of the talk. If there are any more questions, we'd be happy to take them now. If I have a question, if that is okay, if there are no more questions, I'll ask one more question from my end here, Dr. Mukherjee. You obviously have been using digital technology for many years, and you're kind of one of the pioneers in Eastern India in this technology. What do you see as the challenges for using or for growing the use of digital surgical technology in the oral and maxillofacial space? What do you think are the challenges that need to be overcome over the next, let's say, next 5 years?
The biggest challenge is that this requires an infrastructure which is expensive to be created, to start this. The softwares, the biggest cost comes in the softwares, which people discount. People don't understand. Initially, I didn't understand that the cost is not that of the material or the last 3D printing. The technology that is involved in the softwares of designing, because designing, I have used the materials from different companies, so I know how big difference there can be in the output, in the final result, because of the software differences. And this will only be solved when the numbers increase. So that is an important thing, that more and more people need to get interested in this. It has to come in the more of the lectures in our postgraduate curriculum, not only for maxillofacial surgery, but for other people who work on the facial skeleton on this area. If everybody know about this, if everybody know the convenience that it can produce for us, then more people will use it, and only then will the software cost can be nullified, because that cost is taking out the chunk of the cost of what we are having to pay for this. In a country like India, cost is such a big factor, and I think that is one of the biggest deterrents. Another deterrent, which is a kind of like a negative deterrent, is that this technology, as I showed those maxillary reconstructions, this technology is kind of too simple. So there is a risk of people with extremely limited experience trying their hands on the boys' toys theory. And I have actually seen and removed very nicely made PSIs, but nicely made by the engineer, not very nicely used in the decision-making area by a very young surgeon. That I think some of you can understand what I am talking about. A surgery is not about the technical skill of actually doing the stuff. It is the decision-making and planning that goes behind it, and that is something that requires experience. There is a problem sometimes that experience is something which we do not have to depend on our own experience alone. We are in a vast society, and we should talk to people who are doing these things for some time, and that's how we have experience of 100 years by joining the 5-year, 6-year experience of 20 people. That is experience. So once we do that, then we will be safe, because now there are some PSIs being placed which probably shouldn't have been. Just exactly the discussion like before, that if you place a PSI, a fantastic PSI mandible you create before the radiation is done, you send the patient for radiation afterwards, the PSI comes out and you start screaming that PSI is not a good technology. But that problem is real. So we have to think about it. and there should be a situation where there should be a marriage between the PSI and the young surgeon in some platforms. Like this one is a small one. There should be some official certified platforms where the use should be made clear by people who are using it. Because it is dangerously simple, and that can make some people tempted to use it without any experience of the actual stuff. You first do it in the traditional way, then you start applying the modern technology. That's how things develop.
Thank you, Dr. Mukherjee. That's very well said. If there are no more,
and here,
yes, please go ahead.
Yeah, we are in the junctional phase, and at this phase, kind of it has a risk of being used in a sort of an experimental way, which is not allowed to be done on human subjects. So we have to be particular about this.
Yep. There is one more question from Dr. Mihika Bala, I believe. The question is, what are the other cases where you would try to avoid using a PSI other than the RT case you mentioned?
At present, I avoid mandibular PSI, which have got an intraoral communication. What I mean is, if I am placing a PSI for a mandible through the skin, and there is no teeth inside, and we have no plan of placing teeth, then I am happy with it. But if I am doing the ones which are presently getting popular at certain areas and then losing popularity very fast, are the ones with implants that are sticking inside the mouth, and there is a metal underneath. Those implants, in my experience, I have all, because as such, these PSIs are new. And even in this stage, we are seeing failures of those more often than the maxilla. Maxilla failures are very, very rare, whereas mandibles with a direct connection into the mouth do keep failing. And the reason, as I mentioned, I believe, is the simple thing that water travels downwards. So under gravity, water, this saliva carrying bacteria, is finding its way to go and through capillary action reach the plate, the screw joints, and that is making them fail. So for me, at this moment, in the present technology, I would not use mandibular PSI with implants, with dental implants, I mean to say. If they're all the way completely underneath soft tissue, probably fine.
Okay, thank you so much. Thank you very much, Dr. Srijon Mukherjee. I think in the interest of time, we will move on to the next speaker and the next content. Again, thank you so much, Dr. Mukherjee, for, I know you are traveling and you have taken time out of your busy schedule for this. So we will move on to the next speaker. And if there are any more questions for Dr. Srijon Mukherjee, we can always take those offline, and you can send those to us in any form or fashion, and we will make sure to get those answered. So I'm very happy to say that our next speaker is Dr. Sujoy Mukherjee, and he's going to talk to us about digital planning in CMF trauma surgery. He's going to cover the trauma aspect. Dr. Sujoy Mukherjee is a very well-known oral and maxillofacial surgeon, a consultant and specialist dealing with medicine and surgery of face, mouth, jaws, and neck. He's associated with the CK Birla Hospital, CMRI, for over a decade now, after returning from the UK, where he was trained in the specialty for more than 8 years. Major part of Dr. Sujoy Mukherjee's surgeries include road traffic accidents affecting the head and neck region, oral cancer diagnosis and surgery, facial, cosmetic, and corrective surgeries. His special interest is using 3D technology in maxillofacial surgeries, particularly in the post-trauma defect corrections. He did his graduation BDS from Rajiv Gandhi Health University, Bangalore in 2001, and left for the UK in 2003. Obtained his primary membership MFDS from the Royal College of Surgeons, Edinburgh, and specialty fellowship FFDRCS in maxillofacial surgery and oral oncology from the Royal College of Surgeons, Ireland. As the founder of Steroviz Pixels, I cannot be more happy to invite Dr. Sujoy Mukherjee to kindly give his presentation. Thank you so much, Dr. Mukherjee. Over to you.
Thank you. Am I audible, Shamadip? And am I audible?
Yes.
Green,
Yes.
Shiruk? Okay, good evening, Shamadip, Shirup, Turin, and thank you, Srijon, my colleague, for the excellent presentation on the uses of 3D technology in the current scenario and in future also. Um, Good evening, my colleagues, my young friends all over from Bengal and India. So my topic today is for planning in CMF trauma, because I have the experience of getting the post-trauma defect correction by PSI, particularly with the 3D technique. And I've started this 6 years back in 2017, where I did my first case with a zygomatic PSI. Okay, so I'll put forward 3 cases. As you may be knowing, that reconstruction of maxillofacial defects are quite challenging. The challenge because of this regional complex anatomy and the functional effects. You have to have the functions after the surgery. It's not only aesthetics, functions plays an important role. And what we used to do earlier used to use alloplastic implants in post-surgical defect, I mean to say the post-traumatic defect, with autogenous grafts. It had got some disadvantages associated with resorption, particularly infection and displacement. So in these cases, 3D technology has helped us, and I had the experience of doing quite a few, at least 7, 8 I've done so far, and particularly the orbits, forehead, zygoma. I've not used in the mandible though, as Srijon was mentioning. I'm in the same boat as Srijon is. Mid-face upward gives you better results than the mandible. And recent technologies have led to the use of custom-made computer designed PSIs. So I'll show you a first case, a horrific road traffic accident with severe blow to the face and head neck region, where I should have used the PSI technique, not the PSI, I would say the 3D technique beforehand, so that I could have given a better result. So if I have the pictures, please. So this is the case. If you see, is a shattered mid-face, mandible, the orbits, the medial wall of the orbits, the nose, zygomatic complex, everything is shattered. So had I used this 3D technology earlier, because these patients comes, they are ventilated, we have to operate within 5 to 7 days once they're extubated. So we do not get much time to design the 3D models or do the planning beforehand. So this comes as an emergency. So if you see what I'll show you, all these complexes are broken into pieces. So what the 3D could have helped me is, if I can have the video, please, where they can show me. So this was the phase beforehand. If you go back to the previous slide, please. This is the the next one, please. This is the pre-op on the left-hand side, and this is the post-op, where you can find what we have done is overdoing of the left zygomatic complex. So that is, we over-reduced it. So you could see there's a bulge on lateral to the left eye, which could have been corrected have I had the 3D technology or the 3D pre-planning in my hand. Okay, so this is, I would say, here this comes really handy when you try to place an implant. Particularly, we can see where the bones can move forward to, where the bones and the plates can synchronize to each other. Okay, so could I have this video, please? So if you see, these bones are color coded. If you see, there's a medial wall which is connected to the ethmoid. So the bone initially, where it is moving, is down to the floor of the orbit. So this needs to go up to the base, lateral to the base of the nose, covering the ethmoidal region. Next comes the floor and the lateral wall, the green one, which should move more medially and superiorly. Okay, and it should ideally synchronize with the previous bone. Now, the next one, please. So you can see the bones are moving. Initially, these bones were dislocated in the computer. You could see the supraorbital rim, the frontal bone put back in place in a computer. We need to have only the CT scan of that patient with a 0.6 to 0.5 to 0.6 millimeter thickness in a DICOM, and these guys. They do wonders in the computer, and you could see the bones are coming back to place, and it's like a jigsaw puzzle. And then we are putting the bones back to their original anatomical position, and where you can reduce it in the computer and fix it with the plates and screws. So if you hold this, this is the proper anatomical position it is coming around to before we plan for the implants to bend and to place it satisfactorily. So yes, if you hold it, this should have been the ideal position. Since we did not have the opportunity that time, it is just a few months back we did this case, a couple of months back. So instead of putting this, we overdone the left zygomatic complex, so it was jutting out. So now if you take the plates in, so whatever company you choose, Stryker, Synthes, KLS, Martin, irrespective of the plates and screws, you can pre-bend it and get a preformed plate instead of bending on the OT table. Okay, so you can see the frontozygomatic suture region, the plates are getting in, and this should synchronize exactly the plates we put in into the surgical field in the OT table. It's like a jigsaw puzzle, you know. And this is a simulated surgical planning in this app that helps you can plan the surgery beforehand. Where is it gone? Okay, no. So in this case, in these type of cases, I would say for the trauma, this 3D technology in the printing and previous surgical planning, obviously, as Srijon said in my earlier speaker, that planning is more important than the surgery itself and the designs, obviously. So it can, and we have to make sure the plates and the screws, whatever is there, we can adapt it. The adaptation is very important along with the bone surface. Otherwise, there is a possibility of plate fracture, particularly in the load-bearing areas. Okay, and this combination of digital planning in this app follows a 3D model printing, which becomes a game changer for these kind of surgeries, at least. So I could have made I could have given him a much better facial profile, particularly on the left side, have I had this beforehand. Nonetheless, I'm going to do a secondary post-trauma defect correction for this particular patient. Maybe in 6 months, 8 months down the line, we're going to put a patient-specific implant or take the implants out and do some osteotomies and put an implant in. Okay, can I have the next one, please? This is a patient whom I have done last year, probably last year or so. And this is a road traffic accident where he had you can have the pictures, please. If you could see, there's a orbital complex along with the left zygoma, and you could see the depression on the forehead. The forehead is quite depressed and the bones were shattered and they're into pieces. So we cannot keep the loose pieces in. So we had to take it out because it was interfering with because both the tables of the frontal bone were fractured, and we have to take the small pieces out, leaving a big void there. Yes, one can say we have mesh in our hand, so we can put the mesh in, but the mesh is not a customized mesh. Okay, so we make it, we adapt it somehow and cover it up along with the plates and screws and fix the orbit up. But the results were not desirable. The results happened, he he had a mid forehead depression, which was not aesthetically very good. So the patient wanted to go for a PSI where we can give a evenly contoured forehead. So what I have done is go to the next picture, please. You could see the previously placed on the left hand side of the picture. You can see the previously placed mesh, okay, along which I am trying to remove it and put this PSI on the forehead, and you could see the supraorbital rim also on the left side of the picture. That gives a clear prominence of the supraorbital bones and the forehead, so giving a good contour. So these are the areas where the PSIs have really helped me in post-traumatic defect correction. Next one, please. And this is how we close it. And we have got a good results. I don't know whether we have the post follow-up pictures, or most of the patients after a couple of visits don't turn up. The follow-ups are quite poor in this part of the world. And yes, for these patients, they come maybe twice or thrice, but maximum of thrice, but never turn up later on. So we don't have a long-term follow-up for say for a year, 2 years, or 3 years. So how they are. That's quite unfortunate. Okay. Can I have the... And this is the most recent one. This is I've done more of an orbit, mid-face, and the forehead. So there's a orbital blowout, not a blowout, it's a total floor and the medial wall, lateral wall fracture, which required a post-traumatic correction, deformity correction. So this is the most recent one. I've put a mesh in. Can I have the pictures, please? So you could see the ophthalmos there. It is maybe 3 months, 4 months post the primary surgery, and before the orbital deformity correction. So what we have done, this one, I sat with Turin and the other guys there who were operating. So to make a volume correction, as Srijon said, Dr. Srijon Mukherjee, that volume correction in the orbit is very important. Unless the volume is corrected, the ophthalmos persists. It is an unsightly sight. Okay, so can I have the next picture, please? So this is the CT scan of this patient with a 0.6 millimeter thickness in a DICOM model computer program. So you can see the pre-existing plates and screws, infraorbital rim, and that FZ, the plates are there. So this is the previous one, and we usually give this CT scan to them so that they do the surgical planning sitting along with us. Can I have the next one? And this is the primary planning of how the orbital mesh should passively sit on the floor of the orbit, including the medial wall. The medial wall is very important. How far we can go superiorly, and the floor, how far we can go along the floor. So ideally I keep it by 3.8 centimeter, 3.5 to 3.8. Seldom I go for 4 centimeter margin on the floor of the orbit. So this is a 3 point, as far as I can remember, is a 3.6 millimeter on the floor, and on the lateral wall it goes up to around 2.8 or 3. So which I've shown as a good volume correction. I remember the volume had a deficit of more than 4 cc, so 4 or 6 cc. I do not. So if you compare with the affected side and the non-affected side, so and it is very light, as you all may be knowing. It is so with pores in it, so that it becomes much more lighter. Okay, so this is the initial planning. We mark those areas where you can reduce it further, okay, and where you can put in more. So here you can see the left lateral orbital socket is quite okay, so we do not include that in the PSI, and we have included on the floor and the medial wall. Next one. And this is the volume, orbital volume correction. You could see the left hand side, as I was talking about. I think it was around the normal volume was around 28 cc, and the left one is around 33 or 34 cc. So there's a marked enophthalmos due to the volume difference. So that is how they plan it in the computer. Okay, the next one, please. And this is the approach. Is I use a subciliary approach of placing the implant in. You could see the left hand side, the implant goes in, and one thing I make sure that the implant should sit passively. It should not be active. It should not be active. It should sit passively. So it was all right, and the volume correction was done, and you could hardly see any scar on the left hand side. You can see you can hardly see any stitches around. Okay, so I left the previous existing implant in the infraorbital rim there, and slide the PSI to the floor of the orbit and to the medial wall of the orbit. And I anchored with the I remember 2 screws on the lateral side aspect of the infraorbital rim. Okay, and you could see it's still in the early phase. You can see in the X-rays the placement of the PSI on the left orbital floor and the medial wall. And this is the present picture, I think. Okay, the patient has not turned up yet, probably going to come this week. To see, I could manage, and the volumes were equal. This is the outcome, and these are the benefits we get from the patient-specific implant, particularly the post-traumatic defect corrections. And I have done mostly defect corrections in trauma cases. And the takeaway is, obviously, I think what we face in today's scenario is the lack of awareness to get the PSI done, not only to the patient and the doctors also. Cost is an important factor. Establishing lab with the PSI machines and all is expensive, but we need to be open to new technologies within our surgical workflow, and we have to discuss with our colleagues. Awareness obviously needs between the colleagues and the patients as well. You have to counsel the patients for the outcome of the results, and you should show them the pictures, what you have done so far and what results you have got so far. And obviously, I personally have got good patient outcome and surgical efficiencies. And it is quite, even I have 2-3 cases planned up, mostly for the orbits and the forehead. So I'm happy with the PSIs for the last 6-7 years of what I am doing. Next one. So I would all ask you all, the junior one, the colleagues, the new freshly passed out, be open to ideas of using patient-specific implants, and if not the implants, at least plan your surgery in a 3D technology. At least you have some, you know what you are going to do, what the surgery involves, how far you are going to cut, and what not to cut at the same time, and know what the benefits you can get out of it.
Thank you so much, Dr. Sujoy Mukherjee, for that really wonderful talk. And I believe we are doing really well with time. And thank you so much for walking everyone through the 3 or 3 cases and the key takeaways. I would like to let the audience know that we are open for questions. If there are any questions on this section of the talk, you can either unmute yourself and ask the question on the talk, or you can put that in the chat and I will ask on your behalf. So while we wait for the questions to come, I have a question myself, Dr. Sujoy Mukherjee, if that is okay.
Yes.
You mentioned the time constraint that you face with the fracture cases. How do you see the digital technology, digital surgical planning technology, being used in that, with that time constraint in mind? Or are you thinking this is mostly for like revision fracture cases?
See, these patients usually come through the emergencies. These are emergency road traffic accidents. We don't have much time that we can wait for 3-4 weeks before we get the implants in. Yes, what we can do, even if we do not have the patient-specific implants in hand, at least we can have the surgical planning in a 3D platform. So as I said, if you remember the first case, we overdid the left zygomatic complex, so it was jutting out. So had I had this 3-dimensional technology within 5 days and the models in hand and the simulation of the bone placement, I could have done a better work than what I have done. So time constraints say about 5 to 7 days. You have to get the CT scans, you have to convince the patients, you have to send and get this in the computer, and from there you have to have the models and simulation at the same time. So, and time not only for the days I'm talking about, time for each other. I need to have my time to sit with you guys, and you need to have time to sit with me. So these are the things the planning needs to go on simultaneously. And it is not only one patient we are dealing with within the 5 days or 6 days time period, but it is other patients who are waiting also. So this time constraints is always there in emergency patients. But yes, for post-trauma defects, we can always have time and plan it accordingly.
Okay, thank you very much. I think let's see if we have any questions in the chat. I don't yet see any questions in the chat. I'll wait for maybe a couple of minutes to see if there are any more questions on the trauma aspect of the presentation that Dr. Sujoy Mukherjee just gave. Okay, if there are no more questions, thank you again, Dr. Sujoy Mukherjee. We really appreciate you taking time out of your busy schedule to enlighten us all about the prospects of digital surgical technology in CMF's trauma surgery. Thank you again.
Thank you so much. Thanks.
Okay, so over to our next topic for today, and we are very excited to have the next presenters talking about surgical planning in oncological CMF surgery. First, I would like to thank both Dr. Saidul Islam and Dr. Harsh Dhar, who are together the head and neck surgical team from Medica Super Speciality Hospital, Kolkata, and they will actually collaboratively deliver this presentation. So Dr. Saidul Islam, I don't think needs an introduction. He is very well known. He's an advisor and senior consultant, head and neck oncosurgeon, currently at Department of Head and Neck Surgery, Medica Cancer Hospital. He's been a pioneer of microvascular reconstruction in Eastern India, as we all know. He's been a past president of Association of Oral Maxillofacial Surgeons of India, West Bengal chapter, and he's been an ex-director of AMSI Oral Oncology Fellowship Program. He has an experience of 27 plus years of experience in treating head and neck cancers, 25 plus years of experience in microvascular reconstruction, performed more than 6,000 head and neck cancer surgeries in past 27 plus years, and also performed more than 3,500 microvascular reconstruction of head and neck region. He's also delivered a keynote speech in various national and international conferences, delivered the prestigious Professor T.N. Chawla oration in 2006 at UP King George's University of Dental Sciences, Lucknow, and again delivered that in the 38th National Conference of the Association of Oral Maxillofacial Surgeons in 2008. And he has also delivered the prestigious MSN Ginwala oration in the 38th National Conference of Association of Oral and Maxillofacial Surgeons of India. So again, thank you so much, Dr. Islam, for your time. Dr. Harsh Dhar is a very well-known consultant, head and neck and skull-based surgeon in Medica Super Speciality Hospital. And Dr. Harsh is also a visiting surgeon at ASKM IPGMR Hospital. We are very proud to say that he's a honorary consultant with Steroviz Pixels and also my dear friend. So thank you again, Dr. Harsh and Dr. Islam, for your presentation today, and over to you.
Yeah, hi, am I audible now?
Yes.
Yeah, sure. Thank you, Shamu, for that gracious introduction, and thank you to the entire team at Steroviz for organizing this webinar. I must say, my first two speakers were brilliant, splendid, and I think they have far more experience in 3D planning for oromaxillofacial surgeries than we do because we're just starting out and we have a lot to catch up and reach their level. But I'm sure together we'll get there. Saidul sir, are you there? Are you online? So we're not able to hear you. Uh, I tried calling him just before. He had logged in initially. I had seen that he had logged in. But I think if anybody from Team Steroids can just ring sir up and ask him to switch on his mic because I'm not, I wasn't able to get through to him.
Let's wait for 1 minute, and
Yeah,
I know Turin is trying to call him. Yeah.
yeah.
So again, just for those
So
who just joined the presentation, just a reminder that we are recording this presentation for the benefit of the surgical community. And you know, if there are any questions, we will have a question answer session after this talk. There are questions for Dr. Harsh or Dr. Saidul Islam, or you can put your questions in the chat and I can ask on your behalf. Thank you.
So while we are waiting for Sir to join and to start off our presentation, I would just want to highlight a special feature to all the listeners and those who are participating today that Steroviz is not just about surgical planning for oromaxillofacial surgeries. These guys have done a lot of work with GI. They have a very good like template software for orthopedicians, especially for knee joint replacement. And slowly, steadily, we are trying to develop predictive tool to predict operability in locally advanced head neck cancers. And hopefully, soon enough, we can start off a pilot study involving whoever have difficult cases can join in, and we can try to develop the software in gaining better information about the plane of the tumor with important structures like the skull base or the internal carotid or even the prevertebral fascia. So that is another important aspect that we are looking at. Um, right.
Hello, Dr. Harsh. If you can try to reach Dr. Islam because Turin is not able to kind of reach out to him.
Okay. It might be, he might be doing his prayers because Ramzan has started. So he told me that he might have to go for prayers or something.
Okay.
Okay. Do we want to, or do you want to continue the presentation and maybe he will join in some time? Or do you want to wait for him to join? We are doing well with time, I think. So we have some time on our hands. Um,
Yeah, we do have time. Can I'll just try and once using WhatsApp call because I think the normal line is not going through. So I'll just switch off my audio for a second and call them through WhatsApp.
okay, no problem. Yeah. So while we are waiting for Dr. Harsh and Dr. Islam, I just wanted to just tell everyone that there is a feedback form that we are going to kindly ask you to fill out for those of us who have attended. Because what we are planning on doing is we are actually, this is the first of its kind webinar, but we are actually going to do a webinar series in future months on the same topic for the oral and maxillofacial surgical community. So we would kindly like your feedback on how this session went or how the content of all of these talks that you heard today. So I will put a link in the chat. If you, it shouldn't take you more than 30 seconds to fill that out. You could kindly fill that out. That would be great feedback for us so that we can make the future webinars even better than this one.
Yeah. Hi Shamu. I tried calling sir, but I guess he'll be busy with prayers. So I think we can start and then maybe you can join in. It shouldn't be a problem.
Okay, yes, that sounds good.
Yeah. Right. So
I just put the feedback form link in the chat for everyone. Thank you.
sure, sure. Yeah, thanks. Right. So good evening, friends. After hearing the first two talks on surgical planning using the virtual platform for um, automatic cases, for facial deformities, for facial trauma, in this section we're going to talk briefly about the role of surgical planning in oncological cases, that is in oral, mandibular, and maxillary tumors and cancers. Uh, Before that, we just want to reiterate that when we're dealing with tumors, the concept of margins becomes very important. That you have to take an adequate bone and soft tissue margin of at least 1 to 1.5 centimeters beyond the edge of the induration. The section has to be performed in a three-dimensional way so that your margins are clear and you're able to give good clearance for your patient because that is paramount in any onco surgery. So that again makes it, very challenging to use the virtual platform because your planning and your date of resection have to be close to each other so that what you're planning, you're able to execute those dimensions and those standards remain fixed till the patient comes onto your table. So the planning and your surgery has to be at least preferably within a week's time. And in most centers nowadays who are routinely using the virtual platform for mandibular and maxillary reconstruction, their turnaround time is within about 72 hours of planning, printing the mandible, and then taking the patient on table so that they're bang on as far as the resection goes. So the scope of surgical planning using the virtual platform is number one, and this is not very often spoken about, but for even planning your bone cuts beyond the tumor, when you have a large expansile tumor which is distorting the bony contours, just clinical examination with your eye or just looking at the 2D images that you get on your CT may not be enough. And using the virtual platform, as we'll show in our case, the placement of the cuts such that you're able to rotate the model all around in a 3D format, and you're able to see that your line of resection is not close to the tumor at any point. Because when you're during surgery, or when you're, we often go back and refer to the axial scans that we have, and many times it can happen that although you think that you are beyond the tumor, you may actually cut through the tumor. And this has happened to the best of surgeons. So planning bone cuts beyond the tumor can be much better planned using this platform. Secondly, most importantly, for designing and placement of osteotomies on the fibula flap or any bony donor flap, because if you've planned prior to your surgery, if you know what segments are required, how many osteotomies you have to be performed, or what is the angle of your plates and screws that you're going to place in, you can implement that even before disconnecting the fibula from the peroneal vessels from the leg. You can already do your osteotomies using preformed, uh, with the help of the planning that you have done, and that will not only reduce time, but it will also improve the accuracy, and it will also improve the cosmesis. It will also improve the alignment of the new mandible with respect to the remaining mandible and the upper annulus. Many a times, while dealing with benign tumors, where we are reconstructing using a recon plate alone, pre-bending the recon plate on a 3D printed model can help. And also, when you have a benign tumor where resection is going to be adequate and you do not have to rely on any adjuvant radiation, you can use a patient-specific implant. You need not do any bony reconstruction. The patient does not have to undergo a scar on his leg or a scar on his hip to harvest a fibula or a circumflexiliac bone flap, and just a properly designed and printed patient-specific implant to suit his particular needs, and using a soft tissue flap to cover it can just do the job. And these also are, nowadays becoming kind of the standard of care in the Western countries. And, recent literature shows that the incidence of using bony flaps for benign tumors has actually come down in North America and Europe, where they're more and more relying on patient-specific implants. And the other thing that we can use your virtual planning is to use a zygoma-based implant holder for a dental prosthesis for maxillary rehabilitation. So, in brief, these are the scopes and benefits as far as surgical planning is pertaining to the oncological cases. We go on to the first case that we would want to showcase, and this was a 67-year-old lady post-renal transplant 8 years ago at our hospital itself, who came back to us with an ameloblastoma, an ameloblastoma, which we all know is one of the most common benign mandibular tumors. And ideally, if this was a much younger patient, we would have just, gone ahead, done a good resection and put in a free fibula flap. But because of a medical condition, medical issues, we decided that perhaps just reconstructing using a recon plate and a soft tissue flap would be adequate for her, because we couldn't prolong the surgical time, and the patient had to, we wanted to be as minimally invasive as possible and get her back to the ICU, because she was a very, very high risk, was ASA 3 grade for surgery given her transplant status. So Once we have our actual scans, we did a CT scan with 3D recon. We sent across TICOM images, and in the first meeting that we have with our team partners from Steroviz, what we do is that we go slice by slice. And I've just shown one slice. We go slice by slice and do a good contouring of the entire tumor boundary. And we take the most inferior limit, we take 2 or 3 slices in the middle, and then we take the most superior limit. And once this is done, in the second meeting, the team goes back and they prepare a good 3D version, and they send it back to us, and we can see the extent of the tumor. You can rotate this recon mandible. We can rotate it in 3D fashion and look at it from anterior, posterior, superior, inferior, and even from posterior, anterior. And this is what I was saying, that if one were to look just at the scans, could place my bone cut somewhere just along this ascending ramus. But once you have this kind of a 3D reconstructed mandible, you can rotate it anyhow, and you can draw your lines of resection and make sure, rotating the entire specimen on your online platform, that you are not going through the tumor, and that you're at least a centimeter beyond your tumor boundary at each and every point. So that is the point I was saying, that we harp a lot about using this model for reconstruction, but you can also use this model to plan your resection as well. So in the first planning meeting, we do our resection planning. So here we had placed the anterior resection line at the opposite canine, and we drew an arbitrary line, as you can see over here. We drew an arbitrary line that cuts across the ascending ramus, making sure that we were a centimeter away from the tumor induration. But then during the planning itself, Dr. Islam raised the point that, we've drawn this line here. You may be able to hand us a 3D printed model, but how do we use a fixed reference frame to know that our resection line, when on table, will match what we have planned here? So we decided that this is the sigmoid notch. We took the most inferior point, the dip of the sigmoid notch, and placed that as an arbitrary point. And we took distances from this point on the anterior and posterior borders of the ascending ramus, and we measured these distances, noted them down, and that is how we decided that we will use this fixed reference point and these distances to plan our posterior resection line. So during the meeting then, the resected specimen goes off, and the opposite normal side, that's the resected side, is mirrored onto the ipsilateral side with the tumor. And once this mirroring is done, you can plan for a fibula, you can plan for a recon plate, or you can plan for a patient-specific implant. So although we didn't do a fibula in this case ultimately, but we still used the model to see how we could plan our fibula cuts, and this would require these 2 osteotomies. It was an LCL defect, and this is how we measured our osteotomy angles as well as the length of each bone segment. Sorry. Yeah. Sorry. So now that we've done everything on the virtual platform, we now have to go into the OR, and this was after having raised the soft tissue flaps. This would be our anterior resection line, and as you can see, I go back to that image that we had shown. We used this fixed reference point. This is the sigmoid notch, the coronoid process, the condylar process. We haven't, exposed the coronoid tip and the condylar tip much necessarily, but we use this reference point to mark our posterior resection line, and the distances actually mirrored what we had planned during our meetings, and we were really excited about that, because using this platform for even planning resection is really helpful. So this, as you can see, is the contour of the tumor within the mandible, and we planned our resection lines in this way. So once that was done, we already had a 3D printed model wherein the team had replaced the ipsilateral side with the opposite mirrored image, and we could bend our recon plate adequately on this model and place it onto the patient. I don't have the post-operative images as yet because the patient is a bit shy and didn't want us to click any more pictures. So keeping that in respect, we will not be able to share those images on a wider platform. Uh, this was also done. We'd also planned, and Shamudeep and team were gracious enough to even show us that what we can do in future for these kind of patients is that we could print out a patient-specific model that suits the particular patient's needs based upon our resection lines. And all you need is a good soft tissue over this, and you're as good as new. So functionality can definitely be maintained for benign tumors, and you can use this kind of a metal implant or a titanium implant where you're not using adjuvant radiation. The other thing that I would want to talk about is virtual surgical planning for patient-specific implants for a post-maxillectomy case. This, however, was our team had done along with another company. But then, uh, although this was not something that we did with Steroviz, but it's again just to showcase where all we can use our application. So this was a young 27-year-old gentleman who had been operated 10 years back for a mesenchymal soft tissue tumor of the maxilla and had been radiated in the prior. Um, he developed a recurrence, as you can see, and this time the tumor board decision was to just do a resection. He wouldn't want any adjuvant radiation further. So we planned the resection lines, and then we planned to put in a zygoma-based implant with holders for an upper annular prosthesis. So we also used a stereolithographic model with the guides for our resection. This was the model with the implant, and this actually helped us intra-op. This is post-resection. We placed the implant, as we can see here, and about within 3 to 4 weeks after the resection, we could place his final prosthesis, and this is how the dentition looks. So that is just to showcase where virtual surgical planning can help you. The other thing that is very apt for oncology is 3D planning for free fibula reconstruction. And although we haven't done any free fibulas for onco cases with steroids, and just showcasing the work of a senior friend of mine, this is a mid-third mandibular defect. As you can see, these are the osteotomies that they had planned prior, and same is placed onto the CT model of the fibula with the angles of osteotomy being calculated. And the same is again put back onto the resected mandible. You can plan how to keep your bone segments, what angulature you want, what length you want. And this is actually the final product. So this is definitely something that is happening all over the country, although there are issues with respect to the cost. There are, because the patient has to undergo an additional CT scan of the leg. We need quite extensive planning for planning out the fibula cuts, and time, of course, is of essence. All this has to be done within a week of surgery, and we all know that free fibula reconstruction, these kind of free flaps, are definitely a costly affair. So most patients, back out when they hear that there is an additional cost. But then once you convince them that their prosthesis will be much better for a certain added amount, many of them do agree. And this is something that we have to bring into practice routinely. A lot of our tumors today are involving the lower alveolus, the mid segment. We do a lot of these reconstructions, but then definitely using our platform, using the virtual surgical platform, planning the guides, planning the bone cuts on the fibula can actually reduce your time, intraoperative time, and also improve the prosthesis and functional outcome. So that is our team of oncology at Medica, and we are proud to have Saidul sir as part of our team. So Saidul sir, myself, and Dr. Saurabh Datta, we form the head neck team at our center. Thank you for listening. It was a short presentation because, as I said, we are just starting off in our journey with steroids and with virtual surgical planning, and hopefully in years to come we'll have more cases to showcase. Thank you so much.
Thank you, Dr. Harshdar, for that really enlightening talk on oncological surgical planning for oncological cases in oral and maxillofacial. Um, I would now like to open this up for any questions. If anybody has any questions, please feel free to ask or put it in the chat. Okay, if there are no more questions, I have a question myself,
If
Harsh. So what? Yeah,
yeah, yeah, sure.
yeah. So I have a question. I had a question on your on your talk. The question is mainly around uh, the what are the constraints you have faced, or your team, head and neck team at Medica has faced when trying to use surgical planning, and how do you think a company like ours can address those challenges?
See, one of the main constraints that I feel is that even many of the plastic surgeons are not, willing to explore the idea, or they are not yet convinced that virtual surgical planning can help in the reconstruction process beyond what they are already doing. So a good way to go ahead would be to get more people from the plastic surgery community involved, to get more maxillofacial surgeons. Nowadays a lot of maxillofacial surgeons are doing excellent reconstruction even within the city and of course all across the country. And we need to get the word out to all of them that come see the platform, use this reconstructive planning process, and look at results yourself. So at present in the country, as far as head and neck oncology goes, even I trained at Tata Hospital, and virtual surgical planning was not so big when I trained. But then down south at Amrita Institute in Cochin, theirs is a center which actually is doing one of the largest numbers of virtual surgical planning in Asia. And we need to go across and observe in such centers, maybe do a short-term observership. And I would urge the youngsters to seek out places where they can go and observe this being done live, so that you actually know the benefits yourself. That is one thing, that is spreading the word, because cost comes later. The team, the people have to be convinced that this is something that can actually benefit. Once they are convinced of that, then definitely they will try to work around the costs and try to see where the costs can come down. Right? For example, when we are using a patient-specific implant for a patient with a benign tumor, the entire costs of raising and harvesting a fibula and the entire OR time that goes into that will absolutely get slashed down. And once that itself is slashed down, even the post-operative period that the patient spends in the hospital is going to come down, right? So you're going to save on the costs of your surgery, you're going to save on the costs of your post-operative care, and you can definitely, match up for whatever investment needs to be done for the virtual planning and for getting the model printed. And I feel if you do a cost-effective analysis, actually using a PSI for this kind of benign tumors is going to be much more economical for the patient as going ahead for a major free fibula reconstruction. So that kind of input, if we can share and if we can propagate, that will definitely help to get more patients on board, to help to get more doctors and more surgeons involved in this process. The second thing, which can become a constraint, of course, is availability of a one-stop platform or one-stop team who can provide the surgeons not just with planning, with printing and getting everything delivered within a span of about 5 to 7 days. Because in oncology, as weeks proceed, we've seen that the tumor extent that I had seen for a patient maybe 7 days back, by the time the patient comes on table, I'm wondering, how did it increase so much? So tumors, malignancies, squamous cell carcinomas, which is the most common cancer that we treat of the oral cavity, can grow very fast. So in that case, the moment you see a patient in the OPD and you've planned and convinced them, the next, all the subsequent steps have to go fast. So getting that smoothened out, getting that streamlined, I think that can be done. I think within 7 days, we can definitely do our planning part as well as printing out our 3D model and uh, have the surgery done. So I think those would be the two constraints. Of course, cost, but having said that, not all patients are going to be able to afford 3D planning as far as malignancy is concerned, because we must take into account that surgery is not the end of their treatment. They have to undergo radiation. There's a lot of post-operative care, post-radiation care, and there's a lot of costs that the family has to undergo. So not, I mean, the at present, the way things are in our state, and let's be frank, uh, everybody has a West Bengal state health card, right? Everybody has a West Bengal state health card and they expect free treatment. So the challenges, there are a lot of socioeconomic challenges that we are going to face, but then once you are able to showcase your prior work, many times when I am counseling a patient for a laryngectomy, which is a debilitating surgery, but when I can showcase or show them the video of a prior patient who has undergone a good rehabilitation, they get convinced. So in the same way, if we can showcase our prior patients and show that, see, this is the benefit of virtual surgical planning, definitely, I think about 15 to 20% of our patients may agree to spend that extra amount to uh, make use of this process. So that definitely is going to be a challenge, and we'll have to see how we can work about it.
Yeah, that's very well said. Thank you, Dr. Harsh. So I mean, at Steroviz, we are committed to helping all of you here who have, who are here, as well as your colleagues who are not able to make this
Yeah.
session. But whatever we can do to help you make the case to the patient, wherever it makes sense. Obviously, because we are driven to the same thing, we are driven to make sure that the patient outcomes are improved, and there is an actual clinical benefit to all of this. So. So anything we can do to help that, within West Bengal, across India, and we have also had inquiries up from outside. We are driven to kind of help you in that. So with that, I would like to again
No,
just
that is that
remind
kind of commitment.
Yeah. Go ahead,
Yeah, no,
Dr. Harsh.
I just want to add that the kind of commitment that you and your team, Shirupta and Shomesh and everybody else, Torin, everyone have shown is really phenomenal, and we need this kind of industry support to actually go ahead and provide better quality of care to our patients. I mean, having seen what Sujoy and Srijon are doing, it's really phenomenal, and this kind of work needs to get propagated. People need to know, and people need to know about the industrial partners as well. So, really, your efforts are much appreciated in everything.
Thank you so much. Yes, I think we are coming to the end of our session. I would like to just remind everyone, if you could kindly leave your feedback in the feedback form that I put in the chat, that would be very beneficial. Like anything else, we are always looking to improve. This is our humble effort in trying to spread awareness about digital surgical planning in OMF surgery. But if you have any feedback, we will try to make sure we incorporate it in the next edition of this webinar. We intend to make it bigger and better. So with that, I just would humbly request you to please provide your feedback to us. And if there are no more questions, again, I would like to end by thanking all of our eminent speakers. Surgeon speakers, Dr. Islam, I know wasn't able to make it, but I would also like to thank each and every one of you who took time out of a Sunday evening to, I'm in the US here, so it's a Sunday morning for me, but for everybody else, it's a Sunday evening, taking time out of your personal schedules to attend this. Thank you so much, and we hope to see you again in the future. Our contact information can be found. If you have any other questions for the surgeons, we are happy to answer them. Anything else we can help you with in Steroviz, we're happy to do that as well. With that, thank you and have a good night, everyone. Bye.
Thank you. Amen.